Hello, everyone, and thank you for attending today's webinar, ctDNA Applications for Breast Cancer Trial Design, presented by Natera. I'm Michael Shoshua, and I'll be moderating this webinar. Our speaker today is Dr. Angel Augusto Rodriguez of Natera. You can read his full bio on the left side of your window by selecting the Speakers tab. Just a few technical notes before we begin. The webcast is being streamed through your computer, so there is no dial-in number. For the best audio quality, please make sure your volume is up. This webinar is being recorded and will be available on demand within 24 hours after the event. Time permitting, we will follow the presentation with a Q&A session. Please submit your questions using the Questions and Answers tab on the left side of your screen. Now let's begin. Angel, please go ahead.
Thank you. Thank you for the introduction and welcome everyone to today's webinar. My name is Angel Rodriguez and I'm an Oncology Medical Director at Natera. In the next 45 minutes, I will be discussing ctDNA applications for breast cancer clinical trial design. Can you see the slide?
Yeah.
You can. Okay, sorry. All right. The objective for, well, I can't see them. Okay. The objective for this presentation will be, one, to provide an overview of Signatera's personalized ctDNA assay, to discuss how this assay can improve breast cancer clinical trial design in both the academic and pharma setting, and we'll walk through the possible implications of recent findings to the treatment of breast cancer. But first, a brief introduction of our company. Natera is a diagnostic company, a pioneer and global leader in the cell-free DNA. On a big scale, we identify clinical challenges and we bring solutions always looking for improvements. On a more personal level, we approach every single test knowing that behind each one, there is an individual. As a leader in the cell-free DNA technology, we have performed over 2 million tests worldwide. Our unique molecular methods and technology that yield superior sample prep efficiency and our powerful bioinformatics are protected with over 80 issued or allowed patents. Natera is a publicly traded company with over 1,000 employees, and it generated over $300 million in revenue in 2019. Now, Natera has 3 main business units. It has offerings in reproductive health with Panorama, which is a non-invasive prenatal screening test to detect fetal-derived cell-free DNA. In organ health, transplant health, we offer Prospera, a test to identify early kidney transplant rejection by detecting donor-derived cell-free DNA. And in oncology, the test in which we will be focusing today, Signatera, a test which was purposefully built to detect minimal molecular residual disease, or MRD, in patients with solid tumors. All 3 of these tests leverage the same core technology, combining novel and unique methods of multiplex PCR along with our proprietary statistical and bioinformatics models for detection and characterization of the signal of ctDNA that we are looking. This technology has been described in over 60 peer-reviewed publications profiling Natera's technology in top journals such as Nature, Journal of Clinical Oncology, JAMA Oncology, and Clinical Cancer Research. I'll now provide an overview of Signatera. A lot of major advances have happened in this field in the last several years. Some of the most notable advances that Signatera has achieved are the breakthrough device designation by the FDA granted in May of last year. Signatera is the first MRD assay to achieve this milestone, which speaks to the strength of the data that has been generated to date. As a lab-developed test, Signatera does not need FDA approval for clinical use, but breakthrough device designation helps clear regulatory pathway to support biopharma studies. In addition, Signatera received CE mark approval in Europe, which now makes Signatera available to clinics and hospital systems throughout Europe to support patient management and clinical research. Signatera is the first ctDNA bespoke assay to receive the CE mark. Just last month, Signatera received final coverage determination for stage 2 and stage 3 colorectal cancer, and received draft local coverage determination, which proposes to cover Signatera for immunotherapy response monitoring in all clinically validated solid tumors. The Signatera CLIA test was launched in 2019 with availability in New York State. We completed extensive analytical validation and achieved a full GCP compliance. The fact that we've kept the test as CLIA means that we could keep learning and upgrading our assay. Since the CLIA lab launch, we've implemented over 100 improvements based on real patient data and clinical experience. Our experience and commitment to moving forward has been recognized, and this shows in our long list of agreements with pharmaceutical partners, research organizations, and investigators. We have reached over 50 agreements signed with pharmaceutical partners covering over 15 indications, including prospective clinical trials in colorectal, lung, pancreatic, and in breast cancer. And we have executed partnerships with BGI in China, SRL in Japan, and Foundation Medicine. As previously mentioned, we have over 80 intellectual property assets for the utilization of ctDNA for MRD determination. Natera tests are available in over 90 countries, both directly and clinical and throughout distributors. With high volume of tests, batching and running plates at low density is now avoided and has markedly reduced our turnaround time. And this year, 25 abstracts have been presented or accepted at major meetings, including ASCO and ESMO. Now, it's important to know that there is a spectrum in the use of ctDNA testing in oncology. On the left side is the potential to screen asymptomatic, healthy, and unaffected individuals with the goal of early detection of cancers that don't currently have effective screening methods, or it could improve upon existing screening modalities such as mammography. On the right side is the current use of ctDNA in the metastatic setting, where typically the tumor burden and concentrations of ctDNA are highest. This is what is typically referred to as liquid biopsy to detect mutations that have been linked to either therapy benefit or treatment resistance. ctDNA is particularly helpful in this setting, especially when there's little to no tumor available. Now, shifting to the middle of the slide, identification and measurement of molecular residual disease is where Signatera's strength lies and where we have focused our efforts. Presence of MRD by Signatera after best standard of care curative intent treatment can identify a population of patients that are destined to relapse. You can think of it as a way to monitor our patients with solid tumors the way we have been monitoring our patients with leukemias for decades. Signatera can also be used as a surveillance tool for early molecular recurrence monitoring longitudinally. Serial testing can identify recurrences much earlier than our current standard of care surveillance tools such as CT scans, biochemical markers, or clinical symptoms. Identification of patients with molecular recurrence can allow us to manage these patients with an intensive imaging surveillance program, which could lead to detection of local, regional, or oligometastatic disease that, when treated, can lead to prolonged survival and potentially a second chance of cure, as in colorectal cancer. MRD recurrence could also offer a window of opportunity where patients who are asymptomatic and are destined to recur and have no treatment options to prevent that recurrence could be directed to participate in clinical trials with MRD as an entry criteria. And finally, the third area we focus with Signatera is treatment response monitoring and early prediction of benefit. I'll show you how the dynamic changes of ctDNA and its correlation with treatment benefit can change the landscape of how we design clinical trials and evaluate treatment efficacy. In order to achieve this unique, personalized, and tumor-informed approach with Signatera, a sample of that patient's tumor tissue is required in the initial setup along with the patient's blood sample. This approach differentiates Signatera from other liquid biopsy tests that have a tumor-naive approach and don't take into account the genomic profile of the patient's tumor. Knowing the patient's tumor-specific mutations allows us to dive deeper into circulating cell-free DNA to find the molecule of circulating tumor DNA. The first part of the test process involves performing whole exome sequencing on the tumor tissue and match normal DNA from each patient. Based on these results, we can identify the differences and create a molecular signature of the tumor mutations that are unique to each patient's cancer. We look at all of the somatic tumor-derived mutations and apply a proprietary algorithm to select the most important or most clonal single nucleotide variants and custom design and manufacture for each patient a personalized multiplex PCR assay that is going to target the top 16 clonal mutations found in the tumor. In the plasma, we use this personalized PCR assay to amplify those 16 targets and then sequence to detect presence or absence of that patient's tumor DNA in their blood. The mean of the detected target then becomes the reported result as mean tumor molecules per milliliter. Essentially, Signatera becomes a patient-specific tumor marker that can be used for the rest of the patient's life, from diagnosis to surveillance to monitoring metastatic disease if it occurs. We frequently get asked why 16 genes. Selection of up to 16 genes optimizes our sensitivity, specificity, and stability of the test. But keep in mind that it's not just about the quantity of genes that we select, but rather the quality of those genes. The graph on the left shows the fewer the number of genes you track, the harder it is to find. So a lower number of tracked genes leads to a decreased sensitivity. The higher the number of genes, the more likely we are to find the tumor-related genes at the cost of lower specificity. Basically, the more you look, the more you find, but not necessarily what you are looking for. So false positives increase and the specificity deteriorates. We have found that 16 is an ideal number to track to maximize both sensitivity and specificity. But again, it is not just about the quantity of the genes, but also the quality of the genes selected. Selection of genes based on clonality is more important than selection of genes based on its oncogenic potential. Oncogenes are more likely to be lost over time to selective treatment pressure, whereas passenger mutations are more likely to persist over time. Additionally, Signatera's performance is derived from our selection of genes for coverability of library prep efficiency and sample prep efficiency derived from years of experience with cell-free DNA technology. Having optimized these processes over years, we believe that we have one of the highest library prep efficiency as well as an algorithm that can select clonal variants over subclonal variants. So why do we require tumor tissue, and why is the tumor-informed personalized approach so important? The first reason is that the levels of ctDNA in the early stage setting are exceedingly low. This is a study that we internally examined from some of our data cohorts. We demonstrate here that over half of the patients in the early stage disease in the MRD setting have ctDNA levels between 0.01 and 0.1% variant allele frequency. This is the equivalent of detecting between 1 to 10 ctDNA molecules in 10 milliliters of blood under normal conditions. Although really we can detect ctDNA levels as low as 0.004% variant allele frequency. In order to detect these levels of ctDNA with high specificity, it really requires a tumor-informed approach where you predefine what you are looking for to avoid problems with either false positives or issues with insufficient sensitivity. And this does not seem to be tied to any particular histology. In over half of samples of all histologies that we have examined, we see that patients have MRD at these low levels. Furthermore, patients with these low levels tend to behave differently, with lower levels taking longer to recur without additional therapy. And there is work ongoing right now to understand what is the benefit to adjuvant treatment according to the detection of ctDNA and its levels. Our extensive internal analytical validation studies have demonstrated a specificity of the assay that approaches 100%. In this analytical validation study, the sample level specificity was greater than 99.8%. These results match our clinical specificity of also 99.7%, calculated from our thousands of samples ran to date. We see very few, if any, false positives. Now, this is exceedingly important because even low-level false positive rates accumulate when performing serial testing per patient. And I will later show you an example of how, in a clinical trial with serial testing, even small differences in specificities between two tests can amplify the number of patients with false positives enrolled in a study. Now, if you're designing a treat on MRD clinical trial, a high number of patients will be enrolled who really didn't have true positive MRD detection. Now that I've described the approach to the Signatera assay and the technology, I'll talk about its clinical performance. I've discussed many issues that need to be overcome before a test like this is reliably deployed into the clinic for MRD assessment. The next step is to validate the test. And the way we think of clinically validating these types of MRD tests is to test for MRD status in patients after completion of curative intent definitive treatment, which can include surgery, adjuvant chemotherapy, endocrine therapy, or radiation therapy. We then ask, what is the outcome of patients who have detectable circulating tumor DNA in their blood after definitive therapy, and what is the outcome of those without ctDNA in their blood? Signatera's clinical performance has been validated in 4 of the major cancer subtypes. Shown here are the results of Signatera's prognostic performance in 4 of our publications. The first one is colorectal cancer, published in JAMA Oncology. The second one, breast cancer, published in Clinical Cancer Research. Our initial validation data in lung cancer was published in Nature, and muscle-invasive bladder cancer published in the Journal of Clinical Oncology. Patients represented in these 4 Kaplan-Meier curves completed curative intent treatment. Essentially, if patients test Signatera positive with enough follow-up, these patients' cancers almost always recur. If a patient tests negative, and especially if they remain negative with serial testing, only a few of those patients' cancer will recur. These studies demonstrate that Signatera can identify micrometastatic disease in patients that will experience disease recurrence. And these 4 publications reveal that Signatera can perform better than traditional high-risk factors that we currently use in the clinic to estimate chances of recurrence, such as lymph nodes and histological grade. The Signatera assay is complemented by highly efficient chemistry and high-quality bioinformatics. These 2 key aspects allow us to take a blood sample further than industry standards. First, the sample prep efficiency yields twice more original ctDNA molecules. In the setting of minimal residual disease assessment, efficiency is critical for blood samples that may only contain 1 or 2 ctDNA molecules in 10 milliliters of blood. Our multiplex PCR workflow is highly optimized to reduce error. This is a testament to our experience processing ctDNA with over 2 million cell-free DNA tests and how we have leveraged the expertise to our oncology unit. Furthermore, the assay design algorithm prioritizes targets with low PCR and NGS noise profiles and low cross-dimerization and selects clonal over subclonal mutations. Conversely, in a non-tumor-informed approach, originally clonal and oncogenic mutations may be lost due to treatment selection pressure, or CHIP, mutations, which may be erroneously selected to track disease progression. One remarkable finding that we have seen in several of our studies is Signatera ctDNA detection rate at baseline in patients with metastatic cancer. Remember, ctDNA levels are significantly lower in the earlier stage disease, so if the test can't detect ctDNA in the advanced setting, it won't detect lower levels in the earlier stages. Compared to other methodologies and other approaches, you can see that the Signatera ctDNA assay has higher baseline detection rate and can be designed for almost every patient with any histology, as shown here from data generated in collaboration with investigators at Princess Margaret Cancer Center. One of the reasons that Signatera sensitivity and detection rate is so high and how it optimizes success is the following. With Signatera's approach, one can select a higher number of trackable genes from a gene pool generated from whole exome sequencing, or roughly more than 20,000 candidate genes. In the cohort analyzed, the median number of tracked somatic variants per patient was 16, compared to 3 with a static panel. This 16-plex assay strikes a balance between test sensitivity and assay design success of more than 90%, whereas static panels that would select from a static panel of about 73 genes could perform poorly due to limited genomic coverage and low number of trackable genes. In addition to tracking multiple tumor-derived clonal mutations, the Signatera assay also minimizes the potential for false positives. A tumor-informed approach can overcome issues with CHIP, or clonal hematopoiesis of indeterminate potential, which is an age-related phenomenon where somatic mutations accumulate in cells of the blood or bone marrow. CHIP mutations are the most common source of false positives in ctDNA analysis. and Signatera filters out these CHIP mutations. The reason CHIP mutations are challenging is that there is an overlap between mutations commonly found in many solid tumors and CHIP mutations, for example, TP53. Cell-free DNA of CHIP mutations are almost indistinguishable from cell-free DNA of tumor-derived mutations. It is thought that CHIP mutations are relatively uncommon in younger patients and fairly prevalent in older patients. However, the estimated prevalence of CHIP mutations as a function of age varies according to the sequence method used. Methods that are more sensitive, such as deep sequencing of selected targeted genes, will detect clonal hematopoiesis in more people than methods such as exome. Traditional definition of 2% or greater to lower variant allele frequencies of 0.5%, for example, you can see that the prevalence of CHIP can be higher than 30% in patients over 70 years old. So unless prior knowledge of the somatic tumor mutation is known, it is difficult to overcome issues with CHIP. So I previously discussed the importance of having an MRD test with a very high specificity. So shown here is an example of how even small differences in specificities can be amplified in a trial with the serial testing. So take, for example, a study in which early stage breast cancer, hormone receptor positive, is enrolling patients with MRD as enrichment. With a target enrollment of 700 patients with an estimated 15% rate of recurrence, one would need to start screening approximately 5,000 patients. Assuming 5 time points each with roughly 23,000 time points in cumulative, Signatera has a false positive rate of 0.2%, whereas test B might have a false positive rate of 0.4%. At each screening, with a 99.8% specificity, you would expect approximately 9 false positives enrolled per year. With a 99.6% specificity, you expect approximately 19 patients with false positives enrolled. If the design calls for 5 serial testing time points, then that will translate to an overall inclusion of 45 patients with false positive results. However, using test B, which has double the false positive rate, this translates to an inclusion of 90 patients with false positive results. And in this example, a test with a 99.6% false positive rate translates to an additional 6.5% of patients with false positive results enrolled compared to the trial that used Signatera. These differences are further amplified with large differences in false positive rates and increased time points. So to summarize, why the personalized and tumor-informed approach is so important for molecular residual disease requirements? Well, the ultra-sensitive and specific detection of small traces of tumor DNA are essential for MRD. With a personalized approach, you have 16 variants to track, you have ultra-deep sequencing at 100,000x coverage, and you can eliminate germline and CHIP mutations. Accurate measurements of disease burden or ctDNA quantity, one can measure only clonal mutations reflective of full disease burden with this approach. And finally, cost efficient for frequent repeat testing, only sequence tumor-derived variants and no wasted sequencing of whole cancer gene panels. How can this tool be used to accelerate drug development and affect clinical trial design? I'll focus on these 3 main areas. The first being neoadjuvant, then adjuvant, and in some cases, extended adjuvant, as well as, and finally, in the metastatic setting. We will discuss on how our Signatera technology can be deployed in each of these settings. So the first is in the neoadjuvant setting. So ctDNA assessment has several utilities here, and the questions for us are, 1, can we improve our existing treatment response monitoring assessments such as physical exam, mammogram ultrasound, breast MRI, and biopsies with ctDNA monitoring? Can we improve risk stratification like we do with pathological complete response assessment? Additionally, incorporating ctDNA monitoring in a window of opportunity study where study drug is given in monotherapy can give insight into its efficacy. For example, assessing ctDNA dynamics after 1 dose of immunotherapy prior to initiating combination immunotherapy with chemotherapy. As you all know, assessing pathological response to treatment is now an important risk factor to determine prognosis, and in many cases, the most important one. Pathological complete response can identify patients with a very good prognosis. Lack of pathological complete response can identify patients at high risk of recurrence, but it is far from perfect, as not all patients who don't achieve a pathological complete response experience a relapse of their disease. Roughly 50 to 60% of patients who don't achieve a pathological complete response will not have recurrence, so there is clearly room for improvement. An example of ctDNA application in the neoadjuvant setting is the work that we did in collaboration with investigators in the I-SPY 2 consortium, where we examined ctDNA levels with Signatera at multiple time points throughout neoadjuvant therapy at baseline, after 3 weeks, after completion of taxane therapy, and after completion of systemic therapy before surgery, and compare it to pathological complete response and clinical outcome. So shown here are 2 examples where ctDNA assessment complemented breast MRI results. On the left is illustrated a case where MRI appears to show complete response, but ctDNA revealed persistence of disease after neoadjuvant chemotherapy. Now, this patient ultimately experienced a relapse, and future studies that incorporate ctDNA analysis could divert a patient like this to not de-escalate treatment, or, for example, not to proceed with surgery yet, or to escalate treatment and enroll in clinical trial. Now, on the right, a case with what appears to be residual disease on MRI achieves clearance of ctDNA. Now, incorporation of imaging, ctDNA, and biopsy results during preoperative treatment could guide patients to the best treatment option. If all results point towards favorable, then complete response on imaging, clearance of ctDNA, and negative biopsy results, then de-escalation could be considered. So as you can see here, there are patients that achieve clearance of ctDNA quickly after just 1 cycle of paclitaxel. There are other patients that have clearance of ctDNA after completion of 12 weeks of paclitaxel. Then there are some patients that did not clear their ctDNA after completion of taxane, but did after anthracyclines. Previously, this could not be seen clinically or radiographically as well as we see it with ctDNA. The cases represented in green suggest that these patients have taxane resistance but anthracycline sensitivity. Finally, we also see a highly resistant population in red where ctDNA persists despite best curative intent treatment. We then correlated ctDNA clearance or persistence of ctDNA with outcome. After neoadjuvant chemotherapy, all patients who achieved pathological complete response that were ctDNA negative, 17 patients in this case. For those who did not achieve pathological complete response, which were 43 patients, 14% of those patients were ctDNA positive, and they had significantly increased risk of metastatic recurrence with a hazard ratio of 10.4. Now, interestingly, patients who did not achieve a pathological complete response but were ctDNA negative had excellent outcome, similar to those who achieved a pathological complete response. So these patients who are traditionally believed to have poor outcome actually have outcomes as good as patients who achieve pathological complete response. This data suggests that incorporation of ctDNA persistence improves prognostication using factors because it is identifying patients who have micrometastatic disease that did not get eradicated with the standard treatment. Moving on to platform studies, this design is one that can be an umbrella design or a basket design where either multiple drugs can be tested for a single tumor type, but also one drug can be tested for multiple tumor types. The benefit of applying Signatera ctDNA assessment in this study design is having an early efficacy readout to either expand or close these cohorts. Traditional endpoints like imaging can be difficult and can take years to obtain the results. The question is, how can ctDNA help determine if a particular drug is active for that cohort? Here is the application of ctDNA treatment response monitoring, where we can look at the dynamics of ctDNA, where the changes are seen faster and clearer than imaging response, and also predictive of long-term outcome, especially when there is clearance early after treatment initiation. Drugs or tumor types in which you see response by ctDNA assessment would graduate to the next phase, whereas drugs or tumor types where you see no ctDNA response would close. This can be especially helpful when testing immunotherapy earlier in the adjuvant setting, and I will show you some examples of the metastatic setting where a ctDNA endpoint can accurately predict lack of benefit to immunotherapy as well as predict good outcome. Now, treat on molecular relapse study design is one where you can truly exploit the power of Signatera. Longitudinal monitoring in the surveillance setting for ER-positive breast cancer, where one can see delayed relapses, can identify patients with early molecular relapse. As you know, results of clinical trials that have shown that CDK4/6 inhibitors with endocrine therapy prolong progression-free survival and overall survival in the first-line metastatic breast cancer, and the results of Monarchy presented in ESMO this year, which showed a 3.3 improvement in distant disease-free survival in a very high-risk population. The question now becomes, can we alter the outcome of patients who have evidence of molecular recurrence by initiating a second-line adjuvant CDK4/6 inhibitor approach? As I previously showed, patients who are found to have ctDNA detection have close to 100% chance of relapse, on average 8 months before radiographic relapse. So this type of study is designed to intervene in patients who have molecular recurrence but have not yet developed overt metastatic disease in the hopes of preventing recurrence, delaying recurrence, and improving survival. So if successful, this approach could move ahead current first-line metastatic therapy to become the new standard, the new therapy of choice at molecular relapse, to give the physician and a patient a potential second chance of cure in a patient who would have otherwise developed incurable overt metastatic disease. In addition, this approach could reduce overtreatment as well as healthcare costs. And I'm happy to say that, the 2 such studies are already underway. So the DARE study, led by Rahul Futsai at Yale Cancer Center, is a randomized phase 2 trial of ctDNA-guided second-line adjuvant therapy for stage 2 and 3 hormone receptor-positive, HER2-negative breast cancer, where the target enrollment is 100 MRD-positive patients who will be randomized to continuation of adjuvant endocrine therapy versus palbociclib and fulvestrant for 2 years. Here, inclusion of MRD-positive patients only, and hence patients who have close to 100% risk of recurrence, would mean that if the study results positive, the relative risk reduction would actually be the same as the absolute risk reduction. Next slide. So, slide 31? No, the 29. Slide 29? Yeah. So extrapolating data that we generated with Princess Margaret Cancer Center, in which patients with metastatic disease were treated with immunotherapy, we see here that initiating treatment in patients with lower baseline ctDNA levels correlate with better overall survival and progression-free survival than patients with higher levels of baseline ctDNA levels. We hope that, in the previous 2 studies, initiation of second-line adjuvant therapy at the time where there is lower tumor burden and no clinical relapse, it will also translate to better outcomes and a second chance of cure. So a study performed in collaboration with Princess Margaret Cancer Center, and now shifting to metastatic disease, we illustrate an example of the benefit of the application of ctDNA analysis in a metastatic setting. This is a study that was done on patients with a variety of tumor types that were treated with single-agent pembrolizumab. Could ctDNA dynamics predict outcome early in the course of therapy? So in 98% of patients, we were able to identify ctDNA signal to track longitudinally any patients with metastatic disease, regardless of tumor histology. A tumor-informed approach can reliably identify ctDNA that can be tracked over time. More importantly, we were able to show that ctDNA clearance early in the course of treatment, 6 weeks, identified patients who achieved exceptional responders to an IO agent, to immunotherapy. As you can see on the Kaplan-Meier curve on the right, you can see that patients represented by the blue line are patients who achieved ctDNA clearance in just 6 weeks after initiating immunotherapy, and they all remained alive after a median of about 2 years of follow-up. ctDNA dynamics can accurately identify futility of treatment. We analyzed the ctDNA dynamics and correlated them with outcome, as you can see here. 55% of patients experienced an increase in ctDNA after just 2 doses of pembrolizumab. An increase in ctDNA predicted poor outcome and very poor objective responses. So 31 patients in this study continued treatment for an additional 3.4 cycles, or approximately 10 weeks of treatment. 42% of cases with decreased ctDNA achieved objective response on imaging versus only 2% of cases with increase in ctDNA. Now, patients who had progression of disease on imaging on their first scan and an increase in ctDNA levels had a 6-month progression-free survival of 0% and a 6-month overall survival of 50%, addressing the clinical challenge of pseudoprogression. Using Signatera at baseline and then at 4 to 6 weeks, then every 6 to 12 weeks in conjunction with imaging is expected to result in detection of progression of disease and allow for discontinuation of treatment 10 weeks earlier for patients whose ctDNA levels increase from baseline. Identification of ctDNA progression sooner allows to switch to a treatment with a higher chance of efficacy. Clinically, this can clarify the scenario of pseudoprogression, avoid ineffective treatments in patients, and avoid unwarranted immunotherapy-related adverse effects, further deterioration in performance status preventing patients from receiving further line therapy, and also reduce financial toxicity. Now, this approach is expected to reduce treatment that was unnecessary in approximately 42% of patients and possibly improve survival. The other use case is the phase 1 early signal-seeking study, which are increasingly incorporating ctDNA dynamics to better understand early in the course of development how these drugs are working. Some of the offerings that we have here in Natera to accelerate this process is the whole exome or transcriptome sequencing service, where we use the sequencing that we already perform on the tumor tissue. We can also look for novel biomarkers and how they are associated with treatment response or mechanisms of resistance. Additionally, understanding ctDNA dynamics with very frequent monitoring can be extremely helpful in these trials when you are trying to understand how these drugs are working or not working. For some studies, Signatera can be done as frequently as every week or even more frequently to understand a drug's effect on tumor kinetics, or how quickly does it come down after a dose and how quickly does it rise after observing a nadir. This type of data can be useful in optimizing cycle length, for example. And lastly, additional biomarkers can be integrated into Signatera without needing additional plasma. We call this a second pool analysis, where we can interrogate a specific set of genes requested. This may allow for understanding of mechanisms of resistance and timing of emergence of resistance. Even though the core product focuses on clonal mutations, we can also design to additional mutations. So to summarize, here are 6 Signatera clinical trial application scenarios that I have discussed. ctDNA status can become a surrogate endpoint during and after treatment, as it helps you to predict clinical outcomes as early as 6 weeks into treatment. The patient enrichment allows you to select patients likely to respond to therapy due to residual disease presence. So patients that are ctDNA positive, for example. A platform study design allows you to identify winning and losing regimens faster by enriching and quickly identifying active regimens. Molecular relapse is a way to define a new patient population in between traditional clinical high-risk determination at the end of curative intent treatment and stage 4 diagnosis that can allow for treating the right patient earlier than overt clinical relapse. Signatera ctDNA assay also has the potential to improve patient clinical outcome by avoiding overtreatment or treating to undetectable ctDNA or having a timely switch of therapy at the earliest sign of futility. Finally, a second pool analysis allows you to track neoantigens, resistant mutations, subclonal mutations, and driver mutations. So, how can you partner with Natera to accelerate the pharmaceutical development? I want to highlight that we have built up a regulatory framework to support pretty much any study that is envisioned. In the US, we achieved FDA breakthrough device designation. In Europe, Signatera is the first bespoke assay to ever receive the CE mark. And we have ongoing engagement with PMDA in Japan, and we have opened up the Chinese market with a BGI partnership in China, moving towards global commercialization. So key takeaways. Signatera is the first custom-built and tumor-informed assay optimized for molecular residual disease detection and surveillance monitoring. We have clinically validated across multiple solid tumors, which has predicted relapse without further treatment in more than 98% of patients. This is the foundation upon which molecular residual disease-enriched studies can and should be conducted. We have built out an operational scale to support not just the research, but also the commercial experience with the successful Signatera CLIA launch in 2019, and also the broader Natera portfolio. Our more than 50 pharma agreements integrating Signatera into clinical development plans also speaks to the confidence and trust that these strong collaborators have on Signatera. Our more than 60 Natera IP assets covering ctDNA, MRD, and monitoring, which speaks to our leadership in the cell-free DNA technology. And with that, thank you very much for your time. Here are our disclosures. There are disclosures, and at this point, I'd be happy to take any questions. Additionally, feel free to reach out to John Simmons, our Global Vice President, and follow us on Twitter to learn more about Natera and to stay up to date with our latest data.
Thank you, Angel. Now let's indeed move on to the Q&A portion of our hour. There is still time to submit your questions using the Questions and Answers tab on the left side of your screen. We have lots of great questions already, and we will try to get to as many as possible. So our first question here is, could you remind us how an increase or decrease in ctDNA is defined? Is it by tracking specific mutations, or is it a general ctDNA concentration?
Great. So the way the Signatera ctDNA results are reported, it is the mean of the tumor molecules measured of each of the single nucleotide variants that were detected. So one difference between the Signatera assay and other ctDNA assays, which report results as variant allele frequency, variant allele frequency is in essence sort of more of concentration relative to the background cell-free DNA. And the background cell-free DNA can be affected by many other clinical situations, such as inflammation and surgery. The way we calculate the mean tumor molecules per milliliter is based on the tumors that are actually present per milliliter. And so again, we do average out, or we select the mean of the detected variants that were pre-selected of the 16 genes, And the way we define the increase or decrease, at least in the clinical trial that I reported here today, was any increase versus any decrease. And there are certainly currently ongoing clinical studies to further validate the quantity of the rise or the level of rise or decrease and how that correlates to outcome, much like many years ago was done in treating and assessing chronic myelogenous leukemia, where real-world data and evidence is what ultimately led to the understanding of what is a meaningful rise and a meaningful decrease.
Okay. Our next question here is, do you have studies that support Signatera's use in treatment selection?
So with the Signatera assay, we do not report oncogenic, driving, or targetable mutations. Although, in the research setting, we can certainly report the mutation results of targeted genes. How Signatera could potentially be used in not necessarily treatment selection, but maybe treatment continuation or discontinuation is in assessing, the ctDNA dynamics and changes based on an already selected treatment, such as what I reported today with immunotherapy. But as far as treatment selection based on, identification of oncogenic driving mutations, that's not the focus of the Signatera assay in detecting minimal molecular residual disease.
Very good. So what is test turnaround time?
So I know that there's sort of two different parts to the test. The first one, which is the designability of the test, designing the assay, which does require tumor tissue, and it requires performing whole exome sequencing on the tumor, as well as matched normal. As long as we can obtain the tissue in a timely manner, more than 90% of our cases have results reported in less than 20 days. Whereas the subsequent part of the test, which is the serial monitoring, once you've already have identified or once you have manufactured already the assay, it can take a week, 7 to 10 days, less than 7 days to get results for that subsequent time points.
Okay. Could you talk about regulatory filing strategy? Does each patient's 16-gene profile become a unique PMA for that cancer indication and drug treatment?
Sure. So I'm not sure what they mean by PMA, but I would say...
Oh, sorry.
Go ahead.
Hi, my name is Olga, and I'm on the marketing business development team for Signatera. And we have a very robust regulatory strategy that is a global strategy. So we will support your global trials. And we have established pathways for becoming a companion diagnostic and international regulatory approval pathways. Luckily, we do not need to file each individual patient's 16-gene profile with the FDA individually. As you can imagine, that would be a lot of work, and it literally is a 16-gene profile. It's unique to every patient. So luckily, our work with the FDA does not require us to file for every unique patient. I hope that helps answer the question. But please do follow up with us. Email John Simmons, and we'd be happy to talk more in depth regarding our regulatory strategy.
Thanks for jumping in on that. So let me move on to the next question then. Do you find any shared variants or mutations among patients with the same tumor type?
There is. We've actually looked at that, and there's actually very little overlap between patients. Actually, less than 1% overlap that we see in terms of between patients. So again, we are selecting genes that are, although clonal, they are passenger mutations, which generally have little to no effect on the tumor development. So yeah, we see very little overlap between patients.
Thanks, Angel. Another question here about your algorithm for 16 gene selection. Is that based on a general oncogene driver lookup, or is it a sort of AI based on a particular patient profile?
I would say it's more of AI approach than it is general oncogene driver lookup. As I mentioned, the single nucleotide variants are selected from a candidate pool of about 20,000 genes, which we are able to compare the germline from patient blood to the actual tumor. And so although there will be mutations that will be oncogenic or tumor suppressor, our algorithm preferentially selects the most important or most clonal mutation that are less likely to be oncogenic or tumor suppressor genes.
Okay. Thank you. And we have a follow-up on the predictive function question. Do you have data in the metastatic setting that uses the Signatera data to improve OS, like a design like the SWOG SO500?
Sure. So no, not at this point. We do not have data that would, that shows improvement in overall survival. Those are certainly, clinical studies that we would be very interested in. I think especially now, what is very important to note is that there are multiple clinical trials in multiple tumor types, such as head and neck, urothelial, lung, colorectal, where when immunotherapy monotherapy is compared to chemotherapy, although these are all studies that led to FDA indications for immunotherapy because the ultimate long-term outcome favors immunotherapy, we do see a short-term in these studies. We see a short-term crossover where patients who are treated with immunotherapy have a worse outcome in terms of higher mortality in the first, 3 to 4 to 5 months, depending on the study you see. So I do think that there is a potential to actually see a signal where outcomes could be improved with early detection of resistance to immunotherapy and a prompt switch to chemotherapy, which, the studies show, seem to have better outcome, at least upfront early on.
Okay. The next question is, what type of tissue do you need for these trials? What are the requirements for blood collection and blood volume?
Sure. So we do collect tissue in ideally Streck tubes, 2 Streck tubes of 10 milliliters each. And in terms of tumor tissue, either slides that are cut 5 to 10 microns, 10 to 20 slides that are cut between 5 to 10 microns. Formalin fixed tissue, a paraffin block. Obviously, it can be surgical specimen or core biopsies.
And if I could jump in the RUO settings, we definitely can go to a much lower level. So if you're interested in working with us on our CLIA test, then we work with one set of requirements. But if you're interested in our research use only, we're definitely able to be much more flexible and work with a lot less. And we definitely have a great deal of work ongoing, and that is currently contracted and in the works in RUO setting because of the flexibility.
Very good. I think this next question is actually related here. So how do you account for heterogeneity in tumor tissue?
Sure. So, all the studies that we have performed to date included tumors that had heterogeneity within the histology. So what certainly seems to be interesting is that, even within heterogeneous tumor, the fact that we are doing a comprehensive assessment in terms of whole exome sequencing, obtaining about data from 20,000 genes, the fact that we're selecting through our bioinformatics the most clonal mutations basically addresses the issue of heterogeneity. Now, addressing the issue of heterogeneity within, a solid tumor is not the same thing as multiple tumor types, right? With multiple tumor types, 2 different assays need to be done. But heterogeneity within one tumor type seems to be taken care of by the fact that we select the most clonal mutations within the sample.
Okay. Do you screen out germline mutations like BRCA1 from the patient's Signatera signature?
Absolutely, we do. And that is the process of sort of similar to the CHIP process, where, we look at whole blood sequencing, and the patient sort of match normal blood, and we compare that to the tumor tissue. So if we see mutations that are germline, we would exclude those from analysis.
Okay, very good. What tissues do you use in the metastatic setting where there are many lesions?
Sure. I mean, for the safety of the patient, we would select the one that is most sort of clinically indicated and clinically safe for the patient. Selecting a sample that has been previously treated, whether it be with neoadjuvant therapy or whether it be at recurrence, actually enriches for a sample with mutations that we are most interested in, right? The ones that have been enriched with clonal mutations of the resistant type.
Okay, very good. And so this next question will be our final question. We had a lot of great questions today, and we could not get to all of them, but we'll try our best to get back to everyone who submitted personally after the webinar. So, is Signatera only applicable to solid tumors, or can it be used for hematologic malignancies as well?
Sure. So for hematological malignancies, we do have data with lymphoma and multiple myeloma where the test can perform well. However, there are some challenges with assessing cancers like leukemia, where the test may not perform as well as we like. And not to mention that within these tumor types, essentially there already exist. Tests to look for molecular residual disease essentially already exist.
Okay, I think we have time to squeeze one last question in. Dr. Rodriguez, what have you heard from patients using Signatera?
Sure. So most of the patients that we have heard from that are using Signatera, of course, are patients with stage 2 and stage 3 colorectal cancer. And for the most part, and this is, coming more from, patient advocacy, and this is, very readily available as far as, hearing it straight from patients and patients advocacy. You can reach out to, Colon Town, for example. It's been largely very positive take of what the test is, what the test means. I think there is a very important component of, talking to a patient about what this new technology means and what the implications are, once a test is either going to be considered, going to be done. But largely, the feedback from patients and patient advocacy groups have been positive.
Great, thank you, Angel. And so thank you for attending this Fierce Pharma webinar and submitting so many great questions. I'd like to thank our speakers for participating and Natera for presenting today's webinar. This webinar has been recorded. You'll be able to access the recording within 24 hours using the same audience link that was sent to you earlier. Thank you again for joining us, and we look forward to seeing you at future events.